syndrome because she was my very first patient that I ever saw with this syndrome, and I couldn't for the life of me understand as a speech pathologist why a tumor in the back of the brain impacted speech to such a great degree, and I couldn't understand it, and so it made me really dig and dig and try to find answers as a clinician, and then actually drove me to get my PhD. So I have to always just say thank you to Maddie for um, coming to me at a time in my life that I think it was a good timing for us to meet under, of course, not great circumstances. But I do give you so much credit for that. And so it's wonderful to see you. I want to introduce the rest of the team that's here. I know Denesh is here. Denesh, do you want to introduce yourself?
Hey everyone, my name is Denesh Ratnassingam, pronouns he, him. I'm a pediatric rehab medicine attending physician at Children's Mercy Hospital in Kansas City, Missouri, where I have a focus for patients with oncological diagnoses and specifically have been partnering with our oncology team as well as our rehabilitation team for the care of patients and families who have postoperative pediatric cerebellar mutism syndrome or pediatric posterior fossa syndrome. So nice to meet everyone. Just have a great reverence to be a part of this tonight. Thank you so much for having us.
Thanks, Denesh. Karin?
Hi, everybody. I'm Karin Walsh. I'm a attending neuropsychologist at Children's National in Washington, D.C., and have been working with Sharyl and others on also really trying to understand this thing called posterior fossa syndrome or cerebellar mutism syndrome, why it happens, how we can perhaps, avoid this in the future, and in the meantime, how we can help kids and their families and then young adults as people keep growing, manage the repercussions of this and have good quality of life and reach their goals. And again, thank you for having me as well.
Lynn? Let's do Lynn Covitz first.
Sorry, I'm technologically not great. Hi, guys. I'm Lynn Covitz. I'm a pediatric psychologist, also at Children's Mercy in Kansas City, where I get to work with Denesh and have the great privilege of working with him on our team. I am been a clinician focusing on our hematology oncology families for the past 30 years and have been able to work with them both in our developmental and behavioral clinic as well as on our hematology, oncology, and patient unit. Very grateful to have been invited to work with you guys tonight.
Thanks, Lynn. And Lynn Tanner.
Hi, everybody. Thanks for having me here. I am a physical therapist and now the scientific director of physical medicine and rehabilitation at Children's Minnesota. I'm also the CEO of Your Steps Health, which has developed, I guess, an app for pediatric physical, occupational, and speech therapy. So I have worked with kids with cancers for 24 years, both treating and then doing research studies on focus on neuropathy in children with cancer in physical therapy for interventions for children with cancer. And I just am here to learn and share what we've learned.
Thank you. Wonderful. And Kristen Seismanek cannot be here. She's a director of rehabilitation at St. Jude. She's part of our group as well, but is out this evening, unfortunately, due to a migraine. So I just wanted to let you know we do have this international working group called the Posterior Fossa Society that is a multitude of disciplines. We have neuroradiology, neuro-oncology, psychology, pediatric neurology, you name it, and of course all the rehabilitation professionals that work with children with posterior fossa tumors, some who develop posterior fossa syndrome or CMS, cerebellar mutism syndrome. I'm going to use those two interchangeably because we haven't landed on one term quite yet. And then children who have those posterior fossa tumors and then don't have CMS or PFS afterwards. So Karin was one of the founding members, like she'd said, of this organization. And the whole mission is to really minimize the incidence of of PFS or CMS. If we could wipe it off the map, that would be our ultimate goal. And so we've got our neurosurgeons who are working diligently at finding new ways of resecting tumors to preserve very critical brain structures and pathways. So our patients aren't coming out with as many challenges as they had in the past. So they're working really hard on different techniques and protocols for surgery. And they work real closely with our neuroradiology, our imaging people who are, of course, experts in helping us, locate some of those very critical pathways and anatomical regions. We also have a group that's dedicated to working on a better way to diagnose and score posterior fossa syndrome to help us diagnose it a little bit better and more cleanly. And of course, then there's our rehabilitation group, which is really represented here. And we're made up of physical, occupational, and speech therapy. And Denesh is our physical medicine and rehab doc. Representation. We also have neuropsychology and psychology in this group. So as you all know, of course, the posterior fossa region is located between that cerebellum and the brainstem, and can really, as a tumor develops, can really wreak havoc on pushing in on that brainstem or putting pressure on it, and as well as putting pressure on that cerebellum that can cause some symptoms. However, the issue of the posterior fossa syndrome or CMS is really a surgically induced injury, because after the tumor has been resected, of course, structures can get damaged just from resecting the tumor. Especially a number of years ago, the goal was to get the entire tumor out. And of late, some of the surgeons are starting to say, is it okay if we leave a little bit of that tumor to get after the surgery, to spare some of those critical brain areas and then hit that with radiation? So they're making some changes to, like I said, the way they're doing things to try to minimize the occurrence of the posterior fossa syndrome. But we know that there are these pathways that connect that cerebellum to our critical parts of the brain that control our motor skills, cognition, or the way we remember things, or the way we can problem solve or attend to things, and of course, speech and language. And some of our colleagues that have been speaking in our group even went so far as they've been able to anatomically kind of separate out the cerebellum. These are different views of the cerebellum that we have. They've actually been able to pinpoint what parts of the cerebellum are responsible for speech and language, what parts are more dedicated to emotional regulation, and what parts are dedicated more to cognition. So they've been able to piece out what parts of the cerebellum do what, which has really been quite a breakthrough, and really helps us understand the symptoms that we're seeing in our kids and young adults with posterior fossa syndrome. And that brings us to this schematic of all the different symptoms that can come along with this diagnosis. As you all know, that cerebellar mutism is right at the center of this schematic, but of course, early on, we see like a lot of that irritability. But there's, of course, challenges with motor skills, challenges with speech and language, and then, of course,
I don't know how
neuropsychological
to
with like
control the
depression
balls.
or challenges with that emotional regulation and cognitive features. So there's lots here, and it makes it so challenging to study because there's so many different symptoms. We call this kind of a constellation of symptoms, and that's one of our biggest challenges, is trying to really figure out what symptoms are driving other symptoms, and what are the core causes. And then finally, I just wanted to share, and maybe this might be some new news for some of you. We're starting to figure out some of the risk factors for PFS. For example, the tumor type. If the tumor type is a medulloblastoma, there's more chance of acquiring PFS after surgery. If that tumor is right in the middle or midline, not on one or the other side, the children tend to have more likelihood of getting PFS. If there's any brainstem involvement, of course, if the tumor is a larger size, or if the surgeons had to use something called vermis splitting technique. And the vermis is the very middle or center of the cerebellum. So that means if they had actually kind of split the cerebellum to get into remove the tumor, the surgeons are finding that technique tended to have a higher incidence of kids having that PFS. What we still don't know is, well, are boys or girls more likely? Is there the extent of the tumor resection? It is, hydrocephalus. Is that maybe another factor that might lead to PFS? We don't know some of those things, but we do know we have some risk factors that we can start to educate families and patients before they go into their surgeries now better than we used to. And these are our goals. We're working on identifying physiologic markers for CMS, so we can do better diagnosing, but also then chart progress over time. We want to create standardized battery of assessments for rehabilitation, and examine really the patient and family experiences in rehab and try to make those the best we can. So those are our priorities. That's really the Posterior Fossa Society in a nutshell, especially our rehab group. I want to make sure we have it open to questions. So I think I will just pass it over to Stacia. And how do we want to manage questions? Do they come through the chat, or do people unmute themselves?
You know what? I think that it would be great if people want to unmute themselves. That would be great, just one at a time. Maybe if you raise your hands between all of us, we can just. So if
Great.
any,
And then within our team, maybe we can just kind of figure out who wants to field that question, because I think certainly some are going to be, maybe better suited for our physical therapist or psychologist or our physical medicine and rehab doc. So we'll kind of field them that way.
and then just as in the chat, if people want to put the age that their child is, or if, hi Emma, if you're the survivor, if you want to put your age, just so we have an idea of who's here and kind of what stage in life you're working your way through. So anyone want to kick off the questions?
I
Okay.
will.
Go ahead, Erin.
Okay, so I'm actually not Erin. I'm on her Zoom thing.
Okay.
I'm Kathy. That's my daughter is Erin, and she's 26, and she had her tumor was resected when she was 4 years old. So it's a long time on this road. So are there any new like whatever treatments or things that have come out that could help with repairing the brain? Or, I mean, I know there's not any like repairing of the brain, but I've read a lot of stuff on like the transcranial magnetic stimulation and things like that. Is anybody looking into anything like that or using anything like that? Clinical trials, anything along those lines?
Actually, I can answer that one if everyone's okay with that. This is what I did in my doctoral program is study learning how to use the TMS, transcranial magnetic stimulation. And for those of you who haven't heard of that, it's like an electromagnetic signal that is kind of painlessly passed through the skull. It feels like somebody's flicking you in the head. It's kind of annoying, really, actually. But it's a way to non-invasively stimulate different parts of the brain. It's FDA approved for sleep disorders. It's FDA approved for depression and anxiety. It's not yet FDA approved for rehabilitation, but there are research studies going on in stroke populations and brain injury populations, and quite a few for the last 20 years, of us understanding how to use it for motor impairment, specifically for different types of ataxias, and that's where my research line is driving right now. I'm probably wouldn't be for about 2 more years, that we would then start a trial for this population, either using the transcranial magnetic stimulation or another one that's called transcranial direct current stimulation, another way to really slightly, stimulate the brain in a very non-invasive way. So So yes, there are some of those treatments. The issue with some of them is we don't always know the right place to stimulate, the right dose to stimulate, and like how long. And we do know that it wouldn't be like you come in for, 5 or 6 or 10 sessions and then you're good. I think it would be something that would be a ongoing treatment where for depression, I know patients come in sometimes 3, 4 days a week and get their treatment, sometimes 2 days a week, and it's ongoing. Um, but I think that holds some promise, but we're a little ways out. Like I said, my clinical trial probably wouldn't start for a couple more years. But I'll certainly make sure that Keisha and the organization know about it. And if I hear of anybody else using these techniques for a clinical trial, I absolutely will let Stacia know.
I was just
Mhm.
going to add, Cheryl, that we have plans too, that is probably timing wise, maybe even just a little certainly behind yours, but there's a little bit about the timing too, and whether we can use that. And I know in maybe with your question, this isn't as relevant, but we also are thinking of doing this much sooner, right after surgery, and getting into that space of kind of recovery. And seeing if we can make, some preventative measures, I guess, is really where we hope to get eventually.
I have a question kind of to piggyback off of that a little bit. My husband and I have been looking a little bit and starting our research on red light therapy, and we've seen some used in therapies, and like specifically, using a wand right in that area. And I didn't know, I mean, have you guys used that, seen anything about that? Is that even something that falls under the PFS? Like would even help?
Has anybody had experience with that? I have not.
What
I
I
have.
can
Aaron
share,
or Kathy, is this?
what I can share about that from a rehab med lens is that it's a continual discussion between the patient, the family, the radiation oncology team, as well as the neuro-oncology team around safety and timing to potentially trial an adjunctive therapy. There just isn't enough in terms of like an evidence-based approach on the frequency and how much to use this specific treatment and kids with medulloblastoma versus posterior fossa society. So there hasn't been a distinction yet in terms of when to use it and how are we classifying using it. But what
And is
we
that
are
because of a fear of it affecting the tumor?
less so that it's more the impact directly on the skin that is receiving radiation,
Okay.
is what our radiation oncologists are working through right now. Is we want to be safe, we want to be timely, and if we want to use an adjunctive therapy, when can we think about this, and how are we also optimizing and preventing further potential complications so soon if our patients are receiving proton beam therapy or more than that, because some are getting direct proton beam as well as radiation to their spine if there's metastases. So the timing, location, and frequency is still something that is in question, as well as how are we going to classify this? Are we going to classify this by oncological diagnosis, or are we going to classify using this adjunctive therapy for those that truly fit under a PFS kind of classification of their symptoms? And so, at least from my experience, it's continuing to be a multiple team discussion, primarily led by the radiation oncologists on timing and safety for those that are actively receiving it, and then piggybacked off of neuro-oncology and the rehab team as a whole. We are definitely not saying no to it. It's just how do we add an adjunctive therapy and how do we be safe with that right now? That is unfortunately what we know in terms of evidence-based protocols, but I'm happy to let others say more if they have more evidence. But that's at least what we're doing, where I'm practicing right now.
I had a follow-up question to that, Dinesh, just because I haven't, I don't have background in understanding how it's used. Would it be something if the patient is no longer getting radiation therapy? Do we know if the red light would cause any kind of problems or damage or not damage, but any kind of
Yeah, that's a
bad
great
side
question.
effects?
Yeah, that's a great question. And the truest answer for today is that we don't know. We don't know the timing of that post-radiation, if there is still a potential impact on the skin, as well as its impact penetrating through the skin in terms of when it's used during or post-radiation. And that's something that we are actively trying to study to make sure that we can create then safe guidelines. And if it needs to be separated by different age groups, that might be helpful too. But at this point, for coming into today, please know that that question is something that we get asked commonly by a lot of family members, because they are seeing this used in other diagnoses, and they are seeing this used as an adjunctive therapy on top of the standardized treatment. But for patients with medulloblastoma, for patients with other tumors in the posterior fossa, and then those that do have a constellation of symptoms that fit under cerebellar mutism syndrome, as of today, there still isn't an evidence-based guideline of when to use it, specifically during or post during the cancer journey for them.
I'm just going to add that we did that with my daughter. We did hyperbaric oxygen chamber. We did all kinds. I don't know. They put her in this giant spinny thing and spun her around a million times for weeks on end, and nothing had any change. So I'm not saying don't do it. I'm just saying for us, I didn't see any change. No different.
You did. May I ask, functional neurology, is that who you saw, Kathy?
No,
For the
for
spinny
that,
thing?
it was actually this place called the Neuro Hub, and they specialize in treating people with balance disorders, and like even going the other way, athletes who are trying to improve. They're already perfect, but they're trying to get more perfect, kind of thing. So everything from brain injury, stroke patients to, you know, people who are just trying to get even
Right.
better at what they already are. So
That's interesting. Thanks for sharing that experience.
yeah, they did a lot of different things with her it was like a 3-month thing that we did, but I didn't see any major changes with any of that. So I've also looked into like stem cell, you know, putting stem cells in and everything. And I've spoken with the doctor at Duke who's doing all that. I've been speaking to her for 11 years about this, but they won't they won't do it to the kids who have brain tumors. So that's another kind of dead end. And she says she doesn't even know if it would make any difference. So again, there's all these things you read about everywhere, but they're not in practice. They're all hypotheticals.
Well, and on our side, we can feel your pain. I think I can speak for all my colleagues when we say research is moving at a ridiculously slow rate. It's slow for us, and I can't imagine how slow it must feel for you, because we want these answers yesterday, and you want them years ago. So I think we all have that same goal in our mind. And when you say you've tried some of these other options and looking at stem cell, I did want to say one more thing about things that are happening in cerebellum. Is the idea of deep brain stimulation, similar to the idea with people with Parkinson's disease, where they put in a deep brain stimulator. And again, they've seen some great results in people with Parkinson's disease. So there's some talk about, is that a possibility to do that into the cerebellum? And if so, you know, who's candidate, who isn't a candidate, how would it work, where do we put it? And again, there's lots of questions to answer before we even get there, but no, those are on the forefront of the conversation about how do we figure this out. I think I saw Doreen's hand up.
Yeah, hi, this is Doreen. This is my first meeting in your group, so thank you for inviting me. So my son, Wolfgang, was diagnosed 2008 with ependymoma in between the cerebellum, located in between the cerebellum and the brainstem. And he was in an induced coma for a week, and when he came out, he couldn't do a thing. And so he's made leaps and bounds, but his major affliction is with ataxia, severe ataxia. So he holds on to walls and counters to walk around, crawls mostly in the house. And then the other big issue is aphasia. So he understands everything perfectly. Even when people whisper jokes, he'll be one of the first people to laugh. But I was just wondering how we could improve his speech, because even doctors don't understand him. It seems like my other two boys and my husband have to translate for him all the time. So I'll get off.
How far out is he from surgery?
Oh, 2008. He's 23 now, so 16, 17 years. But when he came out, I don't know if it's like this for the other parents, but he could not swallow. He had to learn how to eat again. He had to learn how to speak. I mean, he could not say a word until he couldn't even laugh until he saw Stephen, the Goonies, the movie The Goonies, and he just started laughing, and my heart just melted. I was so happy because I felt he was getting better, but little by little, I find that if he walks more, if I hold onto him and I walk him, his gait is better. But this is like ongoing. In his head, I think he thinks he can walk, but when he goes there, he can't stand more than 30 seconds.
Lynn, do you want to take the ataxia, or maybe hit the ataxia, Lynn Tanner, the ataxia piece, and I can try to answer the speech question after?
Yeah, of course. So ataxia, right, when it comes from the cerebellum is basically caused by coordination, timing of movement rather than strength. I will say that strength weakness occurs due to mostly lack of movement, not really related to the actual injury to the brain, I would say. And so why I say that is because it's important that when in PT or when you're working at home, that you know what you're working on, right? So things that, and obviously he's many years out, but even then, sometimes when there's a certain goal, so if you say, I want to be able to, I'm just trying to think of some things from the families, but I want to be able to walk from my bedroom to the kitchen table, right? Every day and not worry that I'm going to fall. Okay, so what does that take? So you can take a task and then we can understand, is the coordination issue in the arm? Is it in the leg? Is it in the trunk? Usually with kids with posterior fossa syndrome, it's more here. It's in your trunk. So even though it might look like it's coming from the legs, it's actually really here. So you got to work a lot on balance and stabilization in the trunk. And so it's important that whoever you're working with as a PT or an OT knows which part of the body is impacted. Sometimes it's both, and then knows your goal, and you can work on that. I will say with ataxia, it's unfortunately repetition. And when that repetition stops, it tends to unfortunately get worse, which is so frustrating. And so the answer to that is what is in my habit every day. So I give the example of somebody coming, I want to go from my bedroom to the kitchen table. Okay, do you eat every meal at the kitchen table, by the way, right? So might even be, because now you're going to work on it 3 times a day, maybe, right? Okay, every time. So working these things into the routine, so if you increase the frequency, a lot of times families will see that it gets better. Even 15 years later, as long as you know exactly the thing you're working on. Is that helpful?
And I would back it up because to say speech acts the same way. Just because he's many years out doesn't mean he won't get better speech. But I would say perfectly clear, perfectly understandable speech might be a challenge. That might be a big ask, but functional speech, functional communication, I think is absolutely possible many years out. And it's the same that Lynn was saying is functional words, phrases, sentences that are really meaningful for your son and high amounts of repetition. We know in rehab, and Lynn probably will laugh when I say this, but when I was trained, we were the nice guys. Speech was the nice guys, and PT were the people that were really hammering out, how many repetitions to do. And now we've been learning in speech that we need to push way harder. We need to be more like personal trainers, like when you're ready to give up on that last repetition of a bicep curl or whatever, your personal trainer's like, give me 10 more. That's what rehab professionals should be doing, because we should be pushing that patient right till they can't do another repetition. And I think there's a little bit of a lag. We know that in research, we know that in clinical practice, but not all clinicians are kind of caught up to speed on that. And so I think not everybody in every clinic you're ever going to find is going to know that real high intensity repetition and practice is key to making those changes happen in the brain.
Thank you very much.
If I can just add a quick theme to, I think, what you both just shared there, which is something that we all need from our inter and intradisciplinary rehab teams, is we need to know, like, what are the amazing and awesome things that your child does, and what are your goals specifically with that? Because it's our job in each of our individual specialties to really fine tune to know, okay, this is the impairment. We know this was the diagnosis. We know this is the constellation of symptoms. These are the impairments, and we are going to work on this. But without knowing the awesomeness, without knowing what makes your child you, that's what helps us. And for each of our specialties, for rehab med, for PT, for OT, for speech, for psychology, for neuropsychology, for every single one of us on the rehab team, that's what's helpful. And so whether the goal is simple first, and then we know that this is what they love to do, this is what we are trying to achieve, that gives us milestones that we can kind of work towards, regardless of how soon they are from diagnosis or how late they are from diagnosis, so that we can continue to revisit participation rather than revisiting impairment. So I think that's a theme that both Lynn and Sharyl just kind of shared there, and I just wanted to name that. So because that's something that we need from you as survivors, something we need from you as family members, it's something that we need from you as caregivers, because that helps us really partner with you in terms of how we can support you from an inter and interdisciplinary rehab team.
Can I ask a question? I'm fairly new, so thank you guys for setting this up. Our daughter was diagnosed at 10, which was about a year and a half ago. She's 12, so she's 10 and a half, I guess, just a year and a half ago. I'm hearing all this stuff, so being new to this, she had medulloblastoma, and they did a full resection of the tumor, and the initial discussion obviously showed that they did damage her. She needed a shunt, and they sent us to Boston. I'm from Toronto to do proton therapy, and the initial shunt failed. So I guess the surgeon that put it in didn't put it deep enough. That was what the surgeon told us in Boston, and we cleaned it up. I'm struggling with, what do we work on first? That's the biggest question. What do you do first? Do you work on improving their eyesight? Do you improve on working their speech? Do you improve on working their movement? Which part do you improve on? Because each one of them exhausts them to no avail, right? So my daughter's speaking, she's able to move, it's great. I feel like we ended up going to New York for doing chemo, so I felt that just before her 4th treatment, she was standing up, like on a board. We were working with someone who focused on the strength, and he came from a school of PT. I forget the guy's name, from Argentina, but worked on and had her walking. She took like 10 steps on her own, but she lost all of it after the 4th treatment. And then we found, they cut us short, like on the 8 series, and we were done by treatment 5. And we found in January, like, something else came up, and it turns out like she got an autoimmune issue. Being from Toronto, we tried to call sick kids. They just, whatever. They haven't called me back since January, so we just went to New York and they dealt with it, and we're getting some IVIG to deal with it. But I'm struggling with, what do we do first? We're working on PT, or you're working on OT, and Dr. Denesh, I heard what you said. I just don't know. Like, all of it's awesome. She's eating and talking, but which one? I mean, all of them. She's struggling with all of them, and we're finding the biggest challenge is probably emotional and behavioral, because I don't know whether she's going to get out of bed in the morning. Like, I got a shot of winning blackjack, to be honest with you. Like, we don't know whether she's going to be exhausted or whether she's going to be upset or whether she's going to be happy, or like, we just have no idea. So what do you work on first? That's, how do you stabilize? Is how do you get to a stabilization, whether it's sleep stabilization or whether it's mood stabilization? The other parts seem easy. Getting someone on a treadmill, they run on a treadmill, they get stronger, you know, and I think, you know, Sharyl, you talked about, and I forget who else spoke about, you know, you work on the consistencies, and after 10, 15 years, I mean, I'm not trying to say that that sounds obvious, but like, if my handwriting is bad and I work on it for 15 years, eventually it'll be better, even if I'm not good at it. But how do you do that? Like, what do you work on first so that you're able to do that? And that's, I'm sorry for the long-winded, but I'm struggling with that. Like, I think that I don't even know where to begin, because, you know, because of the shunt and et cetera, like her eyes are damaged, right? So it's permanent, you know, vision loss. She's not blind, but I don't know whether that's an issue. Like, so we're struggling as a family, what to do first. What do you do first?
Ooh, that is a challenge. Thank you for sharing that. Really great question. And I'm wondering if we bring in Lynn Covitz, because you mentioned some of the emotional piece of things, and maybe Denesh, talking about kind of, you know, how you prioritize.
That's a better word. Thank you. How do you prioritize? Because it's not first, but what do you label as priority? And we struggle with this, because I think, do we think, is walking better? If she's walking, will that make her happy? I don't know. I don't know. Like, you know, I guess you guys don't know either, but I'm looking, I guess, for people who have experience, and, you know, we're rookies in this. We're just like, you know, we're just fresh out of chemo in the last 4 months. So 4 or 5 months. So, yeah.
So I think this is a great question for everybody to weigh in on, because it is so multifaceted. Navi, you really kind of crushed it in terms of synthesizing, I think, a lot of the questions that folks on this call probably have and have experienced. The easy answer, and what's going to sound pretty stupid, is what you work on first depends on, you know, your child and your family and what's important and what the needs are. And I'll let others speak about how to prioritize and how to make those decisions. Obviously, though, without addressing the emotional piece and the motivational piece and the behavioral piece, you're going to continue to have a very difficult time. One of the things that can be helpful is consultation with a psychiatrist or a neurologist. There aren't good empirically validated studies that say that for children with posterior fossa syndrome, this medication at this dose is the best thing. A lot of it depends on where you are in the recovery phase, your child, as well as any premorbid conditions they may have had. There's some evidence that if children who had more difficulty behaviorally, emotionally, and certainly with speech and language, are more prone to have difficulties post-operatively and in the recovery phase as well. But that is not 100% by any, you know, we can talk about the research, and we all should. You know, the research is super important. However, every child is individual, and I've certainly had kids who had significant difficulties afterwards with no premorbid difficulties, and vice versa. But having a good support team around you to help get to know your child and help. One of the nice things that Denesh just joined us not very long ago at Children's Mercy, and we are so grateful because he brought in his whole rehab team, and we do work together as a team to do a lot of co-treatment. And I find that that's super helpful in spaces that is logistically possible. So on the inpatient side, when kids are inpatient, super easy to co-treat. So you can have the psychologist in with the occupational therapist, in with a speech therapist, and we can be bouncing things off of each other and making observations and doing in the moment treatment. In outpatient.
I live in Toronto, so there's none of that. We just
there's not much of that here either. It's not like it's available everywhere. Yeah. So from a parent's perspective for you, because my daughter was really horribly with the posterior fossa syndrome, work on all of it all at once. Don't say, let's work on the walking and then let's do the speech and then let's do it's all connected, and you should work on all of it and do as much therapy as you can all at once. And
So, Erin, we really are. We
for
really
us,
are. I'd say the biggest challenge is finding speech. Like, we're just looking for a specific speech therapist who we met in New York, and trying to find someone specific who works with Parkinson's patients around breathing techniques and speaking, because I find that's the issue. Like, she can speak, but she doesn't know how to breathe in her speech, so it's very low and you know, it fades. So we've done tons, like, you know, I'm reading constantly and on all this research, we're flying all over the place. We were in Pittsburgh to see a neuro-ophthalmologist around nerve regeneration. I think Dr. Sahel is at the lead of that. And so we saw the pediatrics version of it, and she told us, yeah, we're maybe about, you know,
have you looked into like the intensive physical therapy for kids? Like it's like
yeah, we're in a place called
programs.
Smile.
Those work well.
Which is like Napa. So yeah, so we're in Smile therapy, which the owner of that company was really the one that kind of speared like the whole Napa. So it is intensive, but like you said, you're working on all of it. But behavioral, I'm finding, is the biggest challenge. Like, if she just doesn't want to go some days, like, there's no fighting.
Well, I mean, from what I've dealt with, I think they acquire autism. I'm sorry. I think they get an acquired autism. A lot of these kids, the cerebellum has a lot to do with autism they're finding lately. And like, before my kid's surgery, she was a freaking super genius. I'm sorry. I mean, she was only 4 years old, but she was reading, she was riding a bicycle, she was swimming by her, everything. And now she's like, so, you know, you don't know one day to the next if she's going to be happy, mad, depressed. When she was younger, she would just, you know, you could be sitting in the middle of a restaurant, she'd get mad and start screaming. And you're like, you're 10 years old. Why are you screaming in a restaurant? That's not normal. A normal 10-year-old doesn't do that. She had it was like she was autistic. It was like dealing with a kid with autism. So I think that is part of the emotional part of it.
So I think that's—
What did you do to deal with it?
There's nothing, you treat her just like an autistic kid. You try to calm her down. You try to remove her from the situation. You know, try to listen. At first, I try to deal with it like I would have before, punish her, or, you know, do whatever discipline I would do with a regular kid. She never had a discipline issue before, so I never had to spank her. I never had to do anything like that. So, but you know, it's like, what are you going to do? You can't, you know, it's just not the same as dealing with a regular person with a neurotypical person. It's not the same. You learn how to deal with it. But yeah, it's talk to people whose kids have autism. It's similar.
So Avi, there's definitely some truth to that. And so that the term that I think Sharyl mentioned at the very beginning was CCAS, cerebellar cognitive affective syndrome, which was coined, and I always pronounce his last name wrong, Jeremy Schmahmann, I think, is that right? Yeah. And he's on the East Coast, and he's kind of the grandfather of that. And as Sharyl said, there's a lot of still discussion going on about what we call this syndrome that we're all talking about today. CCAS there's a ton of overlap with autism. And I'd be interested in hearing what Karin Walsh has to say, because I'm sure she's had a lot of experience with this as well, in terms of what the evaluations have been.
The neurologist we're seeing, Dr. Covitz, has suggested that she didn't know whether, when we went to see them in January, because my daughter was she was like a vegetable coming from being like so lively, even during, you know, posterior fossa, she felt it could be either CCAF, but I think they ruled, not that they ruled that out. I'm thinking that maybe she still has that, but she also has an autoimmune issue that we're kind of dealing with. So I just don't know what it is. Is it the autoimmune? Is it a post-surgery damage? Or is it all of it? Like, it's just all of it. You know?
If I can jump in, I think I'm able to kind of reframe this, because I don't think it all fits under one area. So taking a step back, I want to be very, very broad, which is any kid that has an acquired brain injury we are at risk for everything that you're noticing. And then we take the next phase, which is a child who has a neuro-oncological diagnosis, regardless of the type of tumor. The cancer, the surgery, the radiation, and the chemotherapy all come with potential side effects that can impact the entire person. So it impacts the way that they move their body, their speech, their swallowing, their psychological regulation, and their cognitive processing. And then we now put in this constellation of symptoms, which we showed that article at the beginning that was a circle with mutism in the middle, but kind of broken into this pie with 3 areas, and 1/3 of that was neuropsychological symptoms. As a rehab physician, I look at all 3 of those. So I look at the child in the lens of they have an acquired brain injury, and what are the principles that I would use for anybody that has an acquired brain injury? And then I add in this next layer of where are they in their cancer journey, and what are the potential side effects of what's actively going on, and what's the benefit versus harm of us adding in a potential medication that turns that volume dial down on neuroirritability or agitation, or how can we support that from an acquired brain injury standpoint in the context of where they are in their cancer journey for their neuro-oncological diagnosis. Then I take that 3rd phase, which is, okay, so this is a child with PFS, this is a child with CMS, or this is a child with CCAS. And now I'm partnering with psychology and neuropsychology and speech therapy and child life and art therapy and music therapy and massage therapy to figure out how do we optimize all of it so that our goals are appropriate. So I agree with what everyone has shared so far, which is it depends on where you are and what your goals are. Clearly, if you are directly after surgery, directly in active treatment, the main goals, regardless of PT, OT, speech, are how do we get you safe to be able to be at home, right? So that is a combination of gross motor function, fine motor function, speech and swallowing, and cognition. What do we need to do to optimize your child to be safe to be at home? Then when we're at home working on all of those therapy disciplines, what do we now need to fine tune? The other aspect that I definitely want to share with you, and I'm sure that other families have experienced this, is that things recover or things heal or things persist at different times. And so you may have been at some point in this journey of let's really focus on the mutism now, because we know that that should be improving first. And then we're still dealing with this ataxic dysarthria, or we're still dealing with this ataxic gait, or we're still dealing with this poor coordination with their hands. Or as you're describing, this neuropsychological piece has persisted, and it's really now impacting participation with any of these other areas. And so how do we then optimize these other specific things so that all goals are met and all goals are kind of working towards it? Now, when it comes to what do I do first, or how do I optimize one thing first, it goes back to the previous question, which is what is the goal we're working towards with that? And let's focus on that first. And once that goal is achieved, then let's build on and find our next goal. And so that is kind of, at least from a rehab medicine lens, how I approach it, which is starting very, very broad. And what is the things that we can do from an acquired brain injury? What are the things we can do at their appropriate phase of their neuro-oncological treatment? And what are the potential risks of using medications while they're actively getting chemo or radiation? And then outside of their cycles, you mentioned shunts, you mentioned complications with hydrocephalus. How do I weigh that, and how do I take that into effect to make sure that the medicines that I'm recommending, partnering with therapy, are not confounding our evaluation? The last thing I would want to do is turn that volume dial down on neuroirritability, but at the risk is it causes some sedation that we now don't know, is that from a shunt or is that from the medication? So it's really a partnership and monitoring over time. The question in the chat is, how do we find a physician like me in New York? There are pediatric rehabilitation medicine physicians as well as adult rehabilitation medicine physicians that are often linked within academic centers that have an acute inpatient rehab, as well as now there are more of us that have a focus for patients with oncological diagnoses. And so I would start by looking at your academic center and talking to your oncologist, because the chances are is that they know someone that is directly affiliated, if not part of their team already, that they're referring to. But hopefully, Avi, that gives you kind of, at least from a rehab med lens, how I approach this, which is, yes, I want to work on all the goals, just as has been shared, but what are the goals we need to do in which phase of the cancer journey to make sure that we're optimizing it? And once a tiny goal has been achieved, let's then build on the next goal.
and I believe we're doing that. We're very early on, right? I mean, our treatments really just ended at the end of October, so we needed a little bit of just recovery from the nastiness of chemo. We're with an amazing team, like out of New York. We're back and forth, and they're very communicative, even though we're in Toronto, which is amazing. I think someone asked, and I'm happy to share like who we're working with. And they've taken that approach, I guess, just the medications. She's got other issues, like she's developed a tremor, like I said, after that fourth. So we're trying to deal with that. I think she's just having a lot of side effects from the medications. And I think that's the challenge. So we're working on different, we haven't figured out the dosage. Most of the time she is happy and, we're able to get to places, but I think some of the medications just set her back. And obviously some of the autoimmune issues and not the rest of it, on top of that. So I appreciate what you were saying. I think that's great. I guess my biggest question is this group's fantastic. Is the team that, the medical team that's on here, are you guys available for consultation to people that are not in the country? Are we able to hire you or come see you just, with your experience? That's my question. That's another question, I guess, that I had.
Karin, do you want to start with that?
Yeah, I mean, so interestingly, in the United States, I have to have a license in the state that someone is to do a telehealth consultation. However, it's actually at this point easier for somebody not in the United States because those rules don't apply. I'm always happy to consult and provide information and assistance in any way possible with families. I mean, again, I think that one of the things that I think we all know, that those of us that have specialty areas in this topic, is that there are a lot of people who don't really know much at all about mutism syndrome, CCAS, PFS. So I'm sure many on this meeting have also realized that they've been educating providers a lot of times, right? That you end up being more of an expert sometimes than who you're working with. And so that's,
Right.
I think we're trying to fix that through our organization and really spreading the word and getting more people involved. I mean, there was a time when this wasn't even documented, and we know there's significantly greater risk in terms of long-term outcomes for our kids with mutism syndrome. So, but yeah, I'm saying more than you asked, but at least for us personally, I think we're always happy to, get on a Zoom with somebody and try to be helpful in any way that we can.
Thank you. Okay, I'm sorry if I've hogged up this call, but appreciate all
Here-
the info.
Karin, do you want to share your contact information in the chat? And I will also email people.
And I don't have great, I'm at an academic institution, so I don't have a lot of, we don't have a formal clinic, but I am certainly as well available for answering as many questions as I could or doing some sort of consult as well via telehealth. Same rule applies as it does for Karin, as it used to be that I can only provide care for those in Minnesota. Now I'm Minnesota licensed. But I could look into that as well. And I guess what might make sense, Stacia, is would it be all right if I check in with my colleagues that are here and say, who could do a consult via Zoom and then send our contact information to you in kind of one fell swoop? Or
Absolutely. Yep. And I
okay,
send it to the group and the people who weren't here. And I think, it's getting close to 9, and I think a huge thank
please.
you to all of you, but we would love to have one more question. I know there's always so much talk about
Can you?
how do you recognize what is brain tumor or posterior fascia related and what is actually just personality. So I didn't know if you wanted to touch on that. It came up a couple of times. If there's anything that you want to add to that. And then if anybody has one more question.
I think I want to point that one maybe to Karin. Is that, yeah, and
great.
kind of also
What
too,
you
what is
did.
the,
No, you
what
can't.
might
That
also,
asked a question in the chat.
No. Mm-mm.
I was just wondering about if the other piece that I think gets asked a lot is what symptoms are from the tumor resection and then what symptoms might be from the radiation or chemo. And then again, like Stacia said, what is also just personality related, and certainly Lynn Covitz, jump in too. But I think that might be in your wheelhouse.
Yeah, I mean, and I'll say a couple things, let Lynn speak as well. But I mean, I think this is where, for me, I feel like neuropsychology can be really helpful. And we get this question very, very, very frequently about what is secondary to the disease, the treatment, and what is normal, right? So I get this a lot when the kids become teenagers, right? Like, is this because of the things that happen medically, right? Or is this just the normal teenage stuff? And it's a really valid question, right? Because it is hard to decipher that. I do think, every person is an individual. The outcome and the response to what has happened is unique for, while we know themes of risks, every patient that's in my office is still an individual human that has their own strengths and weaknesses that they came into this with, right? Perhaps really understanding the how kids were before. If they're very, very young, it's hard to tell, right? We don't have too much personality per se at a couple years of age, but trying to understand how things were, getting a good history, and then really assessing kids. And when we do that, we're looking for areas that are problematic, but we're also, I think, this is to Denesh's point earlier too, is we're also looking for where are those relative or those personal strengths, how do we use those to build on to accommodate and address the areas that are problematic. So, but I think that there's not one answer to that. It's going to depend on each child or young adult to sort of decipher what is disease related, treatment related, what is perhaps not related at all to that. And sometimes we can't answer all that. It's very complex. And I think, even just your case, like there's a lot of complexities. There's not going to ever be a simple answer to that, but we can work sequentially through that, and for me as a provider, I'm happy to tell you, I don't know if I don't know. And here's how we can try to figure that out, by sequentially looking at different things or treating certain things and then seeing kind of what's next. But I do think in terms of psychology and neuropsychology can be very helpful in answering questions like that. But I'll stop so Lynn can add her comments as well. Lynn's trying to unmute. Hold on.
I apologize. I tried to do this from my laptop when I first signed on, and my laptop decided it didn't want to do this, and my iPad is just really clunky with it. So my executive functioning doesn't work well with this. I really don't have a lot to add. Karin, I think, said it very, very well. Some of my families describe it as playing whack-a-mole. You work on one problem, you seem to make progress, and something else crops up, and we expect that with developmental changes, right? Or the kids are getting older, young adults turn into adults, and things that we didn't think were problems early on become problems later on because of the expectations change, but sometimes their brain functioning isn't keeping up with that. So we mentioned, I think Denesh mentioned a little bit before, that it's hard to pull apart what is posterior fossa versus radiation versus chemotherapy. And the radiation is probably everybody on this call knows is a significant player in this. You as parents can drive yourself crazy trying to figure out what the etiology, what the cause is. Most of the time it's all of the above. It's not A, B, C, but it's D, all of the above. And
that could be a seizure, she said.
And really working sequentially, as Karin mentioned, but also really collecting your own data and working with professionals to help you collect that data, so you can really look at, hey, we tried this is what happened, what worked, what didn't, and what's the next step.
Thanks. That was perfect. Really quick, Fran had a question that her daughter started having outbursts of laughing out of nowhere. And she is 15 years from diagnosis, 14 years from treatment. Just if anybody wants to comment on that, that would be really helpful.
Kathy just wrote back and said something. I don't know if Kathy's still here.
Yeah, so my daughter started having seizures about 9 or 10 years after her initial surgery, which was kind of weird, but that you need to talk to her neurologist because that could be a seizure. The laughing, yeah, just weird ticky things like that. But yeah, I would check with her neurologist.
Okay, all right. Thank you.
So I have can I ask a final?
Yeah.
I know I've talked a lot. Okay, so going back to the rehab of these kids and getting them into different whatever programs or whatever. I've paid to do this with my daughter in the intensive physical therapies, and that's where she's made the most gains. When she's done the 5-week thing for 6 hours a day, 5 days a week. It's intense, it's crazy, but that's where she's made most leaps and bounds. She's an adult now. It's hard to find anything like that for adults. It's also hard to find anybody who even knows what posterior fossa syndrome is. So I bring her into physical therapists. They don't know what they're talking about. I know more than they do, I'm just saying. So, they're working on things and I'm going, this is not what she needs. You're like going completely wrong. I feel like I can do more myself. Are there any programs, or could there be any programs for kids specifically, or adults, whatever, the young adults with posterior fossa syndrome, where we say, hey, we're a hospital who works on this. Let's do a 3-week program for these kids. And I don't care if I have to pay for it out of pocket, where we, put them through different things for ataxia, for speech, for the psychological stuff. She's been to neuropsychologists. They do the testing and then they say, okay, bye. Here's what we found. Nobody ever follows up and says, let's work on this. They just say, here, bring that to school so you can get your IEP. Is there anything where you can make a program specifically for these kids?
A great idea.
It's such a great question. And I think something that is not far from our minds as well, because especially for late effects, because I think you're exactly right. I think there's a lot of programs for pediatrics with that intensity, but it doesn't seem to be anyway as much for adults. And how do you find that intensity? And it doesn't even need to be specific to posterior fossa syndrome, in my opinion. If it's intensity, ataxia, balance training, it doesn't matter if you have, PFS or, if your ataxia is coming from something else, but it would be that intensity piece of things. I question that. So right now, I don't know of any. Karin, do you, or Denesh, Lynn, anybody?
Centers, you mean, that are
Yeah,
focused
like having an intensity program, because Kathy and I, we've been kind of emailing back and forth, and I've been kind of asking colleagues of mine to help answer this question that Kathy's raising. Are there programs out? I checked in with St. Jude's and they don't have like a late effects kind of intensity driven rehab program. I thought maybe they would, but they don't have one. But it certainly is a whole. This is a whole that we're finding that there doesn't seem to be this intensity, these intense programs maybe for young adults.
Well, and I think this is in part related to the fact that we've only relatively recently even understood the long-term impact of PFS. Like, this is just not something the belief around that for the longest time was that once that child is talking again and walking, that's the end of PFS, right? And now we really know much better than that. And also that, that cognition and emotion are also very much a part of this constellation. It's not just the motoric piece of things.
Yeah.
So I think there's not centers because it's relatively recent that we even understand that this is a really important thing to focus on, and that this is a very unique group of patients, and not just in the short term, but also in the long term that probably have needs that we're not meeting yet.
I think a shift that is happening around from a rehab medicine lens to give you a potential avenue for this is that some of us that specialize in kids that are now young adults or even adults with oncological diagnoses is we're part of the survivorship clinics. And so in that clinic, we are the touch point to have a reassessment. And then we circle back with our interdisciplinary rehab team to say, what can we do? Could we benefit from a burst again with therapists that they are familiar with? And do we have the appropriate equipment now as a young adult or as an adult to support them at this next level. So that's been a shift, I would say, in the last few years, and just in terms of the rehab medicine physicians kind of talking about how do we be involved at the survivorship clinic level to then be a part of that discussion, to really be monitoring these late effects, and from looking at these late effects to then say, how do we do a burst? You're right. Really isn't a structured program yet, but what we're trying to do is be a part of these clinics so that we can then regroup with our rehab team to say, what can we do and how do we structure this? Whether it's with the team that has known them through this whole time, if we have an opportunity, or is there a way to do an intensity that is appropriate for them with the equipment and the adaptive tools that we have on hand that would support them.
Can I interject for a second?
Oh, yeah.
This is Doreen. As a parent, I did have our son, Wolfgang. Actually, I think his oncologist suggested it, his neuro-oncologist suggested it, that he be admitted for an intensive program. So I'm a little surprised that no one else has done this, but it was about 6 to 8 weeks, and it had to be in hospital. And he was able to prescribe it, and our insurance did pay for it. So he was here. He was at Children's Hospital in Oakland, so in San Francisco area, Bay Area. And he was there, it started at 8 or 9 in the morning, went till about 4 or 5. So he had speech therapy, occupational and physical therapy, and rest in between. And then they tried certain drugs to help him with his ataxia. That didn't work very well. But in all honesty, I'm not sure how much it helped, but it maybe it was just for him. But as you said, we had to follow up with repetition. And since my husband and I both worked, it was just difficult to do that. Now that I don't work, I'm going to have him go biking. He's going to try kayaking. He's going to try to do strength training with rock climbing. So I'm going to be the rehab coordinator, basically. So that's just an idea from a parent's point of view. So
Thanks for sharing that. It's great to hear that there's an inpatient, and I'm sure there are others in the country that are like that. I don't know of any off the top of my head, but Lynn Tanner and I, our PT that's on, she and I have talked at length about needing these kids and now young adults who are 10, 15 years out from their surgery. They're kind of left out to dry, right? You don't have a lot of options for rehab, and that's not right. I feel like there needs to be these bursts throughout recovery phase to see if we can kind of reinitiate or reinstigate some, give it some oomph, like oomph up some rehab. And there just is not any kind of framework for that. There isn't, I think up until, the last few years, maybe 10 years, rehab professionals were told, well, after somebody has a brain injury, about 18 months after, then they pretty much are stable, then they pretty much don't make a lot of progress. And now we know that's absolutely bogus. We know that kids and adults make progress long after that 18-month window. And so it's us also learning that the brain can change after that time. That's fairly new to us.
Well, again, I want to say a huge thank you to all of you for sharing your wisdom and your passion. I think sometimes discussions like this make you recognize how much is still missing and how far we still have to go. So thank you to those of you who put in the chat different resources that you do have access to. And I loved somebody's idea about educating the providers. And I think you all as a group did such a great job that hopefully we should have discussions like this with the providers as well. I know we always hear from families that they feel like they got thrown into this pretty blindly with not a lot of information to start out with. And certainly, I know somebody just asked in the questions about what the late effects will look like further down the road. And I think that again, people are approaching it blindly. As you said, there's new information and it's a growing field of information, but we really appreciate all of you. And you
Yes,
will
thank you.
share contact, Sharyl, and then we'll go from there.
Yeah, I'll check with my colleagues here
Sure.
who would be able to do that kind of consulting, and then I can compile a list. And I wanted to state too, Lynn just posted in the chat. She's created a really beautiful rehabilitate course for rehabilitation professionals called Create, and it's just about rehabilitation for kids with cancer. And we have a special PFS section in there to try to train other rehabilitation professionals to understand what PFS is. And then also in our Posterior Fossa Society, we just started a new special interest group, which is education and advocacy, which is us trying to educate physicians and care providers and rehabilitation professionals about what this is and what special attention needs to be drawn to this. So we're hoping to, just broaden our reach a little bit to help everybody understand a little bit more about it, so it doesn't fall on the parents and the guardians of our kids and young adults to explain, and our kids and young adults to explain, what PFS is to their providers.
Great. If you can add educators to that list of people that you will share with, good. And yes, Debbie, the resources will be emailed. I'll follow up tomorrow with just an email of some of the resources that you all brought up in the chat. And then when Sharyl gets back to me, the contact information. And Lynn, that's great about that course, but love to learn more about that. Okay.
Well, thank you for the opportunity. And thank you, families and patients, for just sharing questions and stories and challenges. And I just really appreciate your time. It is always so helpful to learn from all of you.
I agree. I'm like, now tomorrow I'm going to be talking to our institution about more. I will say, I know it's getting late, but the research in rehab is coming to do more intensive, so I'm very hopeful. I know our institution and a number of other hospitals are looking at doing more 3-week bursts of like 3 hours a day at different times. So we're seeing more like courses at conferences and things like that. So I'm hopeful that will pick up in these next couple years, because there's a lot of research on it, and so I actually am like now so inspired from you all and bringing that up, because I'm like, we need to do that.
We do. We really do. Yeah. Put it on the list, right?
Yeah.
Put it on the list of something that's really needed. Yeah.
And I have one more thing to add, that as a physical therapist, I have to say this. The research out there shows that physical activity, so moving in any way, right, actually also improves cognition and emotion. So it's really important, and find a physical therapist or find an adaptive PsyD teacher or find somebody that will help you find ways that your child likes to move, because sometimes I know that's been a challenge with some families that I've worked with, and we have worked on it until we found the thing. And so I just think that, long term, when you're looking at health and happiness, whoa, my light went out, and also supporting, you said, what do I do first? Physical activity does work on all those. It is being related to all those areas. So definitely, that is a lifelong thing that we all, including myself, have to figure out.
Thanks, Lynn. So before we all go to sleep, we'll make sure we get a good stretch in and a little great. Okay, well, thank you again. We look forward to hopefully doing this again with you, and just can't say thanks enough for sharing your time and passion.
Thanks again for the opportunity. Thanks, everyone.
Thanks.
Thank you.
Thank you.
Thank you for doing this. Appreciate you all. Thank you.
Cheryl. Thank you. It's good to see you, Cheryl.
Oh my gosh, it's so wonderful to see you both. Oh my, and I'm sorry, but I saw you put in the chat, Maddie, how are you 32? There's no way. You know how much that dates me?
That's great.
You just
It's
started
just-
early, Cheryl. It's okay.
That's right. That's right. It's just lovely to see you both. And oh, it's wonderful to see you, Emma. Oh, I just love seeing all these wonderful, familiar faces. Great. All right. Have a good evening.
Night.
Thank you.
Good night,
Thank
everyone.
you.
Thanks.